Hi there. My name is Paul Sinelekuru. I'm presenting the case study 67 ovarian cancer. The disorder is also ovarian cancer. Patient case introduction. The chief complaint is abdominal pain. History of present illness. The HPI. WD is a 68-year-old woman who presented to the emergency department 3 months ago with a complaint of abdominal pain that started 3 days ago. Moreover, she reported she gained 5 lobes in the last 3 months, although she has loss of appetite. The ultrasound and CT scans of the abdomen and pelvis show the left lower quadrant relatively large, non-cystic, soft tissue pelvic mass. Kidneys and liver also showed multiple solid lesions. Chest X-ray showed several leery half-inch masses in the right lung lower lobe. Laparoscopic surgery showed 3.5 to 3.75 inches of mass in the left ovary with an involvement of the bilateral external iliac node. Tumor biopsies of the left ovary, kidneys, liver, and lymph nodes were all positive for epithelial ovarian cancer. The serum CA-125, the ovarian cancer related tumor marker, the concentration was 190 units per milliliter. To debug the tumor, hysterectomy and lymphadenectomy and bilateral salpingo-oophorectomy were performed. She is now admitted to the special procedures unit to have 4-cycle systemic chemotherapy. Ovarian cancer description and epidemiology. Worldwide, the incidence rate is an average of 240,000 with 66% mortality rate. The risk increases with age and will peak at ages 50 to and 60 years. It is more common in developed countries, according to Budiana et al. 2019. It has no screening test, only cervical cancer does. But ovarian cancer can be recognized by early signs, which include bleeding, vaginal bleeding or secretion, constipation, loss of appetite, abdominal and pelvic pain. Risk factors include genetics or familial history of cancer or personal history of cancer, Eastern European or Ashkenazi Jewish race, infertility, and over 10-year use of estrogen only without use of progesterone. Uh, the HPV vaccine from age 9 to 26 or as a deemed necessary can reduce the risk factor. Treatment includes surgery, chemotherapy, radiation, and targeted therapy, according to the Center for Disease Control 2024. In the United States, ovarian cancer is the second commonest among the 6 gynecology cancers and leads to more death than all other female reproductive system cancer, according to CDC again 2024. Between 2016 and 2020, there were reports of 99,315 new cases of ovarian cancer in the United States, among which there were 69,467 mortality or death. Moreover, 10 in 100,000 women develop ovarian cancer with 60% mortality. This is the incidence rate and the mortality rate. The pathophysiology of ovarian cancer at the cellular level. Ovarian cancer can develop from any of the differential cell types that make up the ovaries, which are germ cells, the specialized gonadal stromal cells, and epithelial cells. However, most ovarian cancers are composed of ovarian carcinomas, which are cancers with epithelial differentiation, and they are also the cause of most related mortality. The main pathologic subtypes of ovarian carcinoma, which are based largely on appearances under the microscope, including endometrioid carcinoma (EC), high-grade serous carcinoma (AGSC), low-grade serous carcinoma (LGSC), mucinous carcinoma (MC), and clear cell carcinoma (CCC), according to National Academies of Science, Engineering and Medicine (NASEM) 2016. Of all these pathology classifications, high-grade serous carcinoma is the most prevalent, accounting for approximately 70 to 74%, with fewer than 5 to 10 stage 1 diagnoses. When the carcinoma has not metastasized, that is, is still contained or restrained within the ovaries. And this is also likely due to the fact that there is no screening test, so usually discovered late. Similarly, AGSC is found in women at later ages than LGSC, with an average age of 60 and 50 years for presentation. That is, the age which AGSC is found at 60 and LGSC around 50 years of age, respectively. Pathologic examinations of AGSCs usually reveal solid growth or papillary with fissure-like spaces, and the tumor cells typified by abnormal cell nuclei or abnormal nucleic cell with variable sizes and shape and numerous cell proliferation, according to National Academy of Science, again 2016. AGSCs generally exist with a widespread anomaly, which includes large masses in the ovaries, omentum, and other endo-abdominal sites, with or without ascites. Genetically, AGSC are unstable and may also be because of perpetual or frequent mutations in the BRCA1 and BRCA2 and P53 tumor suppressor genes. These are the susceptible genes. Since high-grade serous carcinomas are usually discovered at an advanced stage, also due because there is no screening. The preliminary phenomenon of tumor regenesis is unclear. Um, However, notwithstanding, research suggests that a large part of AGSCs develop from the fallopian tube epithelium relative to the ovary as it was first hypothesized, according to National Academy of Science, again, NASEM 2016. Clinical manifestation uh, pertinent subjective data as follows. The patient denies fatigue, bloating, constipation, urinary urgency, vaginal bleeding, and sensation of pelvic pressure. The chief complaints are, as said before, abdominal pain, the history of present illness, HPI, as said or as discussed earlier, the past health history, diagnosis, the patient was diagnosed with, it's not really a diagnosis, but it's a past health history. She had menarche at age 11, menopause at age 54 years, diagnosed with asthma at age 3, resolved at age 15. She had endometriosis, 15 years of age, hypertension, 6 years of age, uh, not 6 years of age, hypertension 6 years ago, seizure disorder, she had seizure 4 years ago, related to major motor vehicle accident, which she sustained traumatic brain injury, TBI. Currently, the seizure is well controlled with anti-seizure med. She's been seizure free for 2 years. Surgical history include cholecystectomy for gallstones and cholecystectomy, cholecystectomy for gallstone and cholecystitis. Family history: she is separated from her husband of 27 years. She has no children. Her mother and maternal aunt died from ovarian cancer. The father is alive but has a history of hyperlipidemia and hypertension and advanced coronary artery disease. Maternal grandmother is died from complications of cervical cancer at age 53. Uh, Social history. She smokes 1 pack per day of cigarettes and it's been for 9 years now. She lives alone. She denies alcohol and drug abuse. She's a strict vegetarian. She started being a vegetarian 6 years ago. She's not currently sexually active. Allergies include adrenaline, which causes lupus-like syndrome. Aspirin causes stomach cramps for her. Current medications are carbamazepine, 200 milligrams by mouth 3 times per day. Amlodipine benzoate, 2.5 milligrams by mouth every day. Pertinent objective data, physical examination, vital signs, they are within normal limits. The weight is 130. The respiration is 16 unlabeled. And the other vital signs like temperature and pulse, they are within normal limits. The temperature is 98.6, pulse is 82, height is 5'3". Head to toe uh, assessment, the neck, uh, the EENT, the breast, the lungs, the cardiac, the GIG, musculoskeletal, and neuro. They are all unremarkable aside from benign fundi in the eyes. Diagnostic text, uh, the laboratory blood test results, they are mostly within normal limits. Some are not within limits. Sodium is 138, and also creatinine is 1.8, white blood cells 78,000, 7,800, potassium is 4.7, fasting glucose 105, AST is 32, chlorine is 100, hemoglobin is 12.7, LT is 30, bicarbonate is 24 milliequivalent per liter, hemocrity is 43%, bilirubin 0.9, BUN is 26 milligram per deciliter, platelet is 160,000, and the CA125 tumor marker is now 93 unit per milliliter. The role of the APRN, advanced practice nurse, underpinned by the Christian worldview, the APRN must design treatment interventions that border on the following considerations for women living with ovarian cancer. Number one, diagnosis and being told. These are the topics that needs to be covered by the APRN. The unexpected diagnosis, because the patient may think the private his care provider did not consider to rule out or rule in ovarian cancer earlier. Number two, battle metaphors. The encouragement given to patients to be strong and fight the disease may seem to put all the weight of the responsibility of care on them, and that the healthcare providers are not accountable. Treatment expectations. There's a well-known traumatic experience of chemotherapy that leads to women questioning whether the treatment is even worth it because of the worst of feeling they now feel compared to before even the diagnosis, because of chemotherapy, because of radiation, because of a lot of side effects, and even some people lose their hair. Being normal and being different, their sense of normalcy is distorted due to fatigue, physical changes like loss of hair, radiation therapy, chemotherapy, and altered perception of self. Sense of being heard, you need to invest effort and time to listen to patient stories, address their concerns. Also related to the cancer being caught late and the feeling that their healthcare provider do not listen to them, uh, making the number. Another one is making sense of their new world, finding meaning and purpose in life for them, helping them to find meaning and purpose in life, even if the disease, ovarian cancer, is terminal. Inability to have children, like the current patient has no children. Explanation and care as related to hysterectomy with oophorectomy. Even if the person is of age to have children, may not be able to. Issues of sexuality and signs and symptoms may be related to surgically induced menopause, and how to manage relationship with their spouses or significant others. Also, can in terms of making love or having sex, irrelevance of most support groups, then find relevant support groups based on age, needs, and other characteristics. The next slide talks about the question, what's the significance of the Benin fundi finding the eye? Explain the author CA 125 as it relates to the patient first CA 125 test, which is the ovarian cancer tumor marker. Number three, expand on the purpose of amlodipine benzoate uh, therapy. Last slide is about the references, and thank you.